Hi, Dr. Chandy. Welcome to the
Good
podcast.
morning.
Morning. So I'll just straight away jump into the only question that probably from a patient point of view people would like to ask from a senior cardiologist like yourself. And the question is that post-COVID, we have seen that a lot of young people
Yeah,
are dying due to sudden
yeah.
cardiac arrests. Um, First of all, why is it happening? Why is it like a silent risk?
Okay,
Like I am 37, 38 years
okay.
old now, and I am also worried, or I also get fear when I see such
Yeah,
news. But from a patient point of view or a consumer point of view, I don't know how to take care of
right,
my
right,
cardiac health, and I don't know what is happening in
right.
my
Okay.
heart. So I would just like you to start with this.
So a good question and very relevant to today's modern lifestyle and the heightened awareness that we all have about our health. You mentioned
Yeah.
post-COVID. I'll let me first speak from a public health perspective. You know what? The good thing that COVID did to all of us as a population is that it has increased our awareness of health. Till then, it was a chalta hai attitude. But COVID was so devastating that it kind of lifted our awareness about everything, about our wellness, about illness. So there's a heightened sensitivity about this. Plus, the media is picking up a lot more of these anecdotal events than before, which is again good and bad in one sense because actually, if you put it against the large population denominator of India, it is not that it's an epidemic of sudden cardiac death, but definitely it's a little
Mhm.
more than what we had pre 2021. And that's a mix of actually sudden cardiac deaths in the young people is more and is being reported
Mhm.
more. So a combination of the
Okay.
two is, bringing this to our radar screen, more diligently, and we are all kind of reacting to that. Okay.
So do you feel that such sudden cardiac arrests have always been there? There is not an anomaly. It's just that it's being
No, yeah,
uh, made
yeah.
viral more.
No, I would think that definitely there are more people in the younger age group. When I say young, let's say under 45, who are dying of this wide bucket called sudden cardiac death. We know it because we ourselves have got friends whose friends have been victims of this,
Yes.
or our own relatives who have unexplained in the pink of health have suddenly collapsed and died. So it is not untrue that this is happening, but it's reported, in multiple times. So it is kind of exaggerating or making the heighten, which I think is good because it helps us to then see what are the ways by which we can prevent. Who knows it will happen to us? So it's a good thing that is happening, and definitely there is an increased incidence of sudden cardiac death in the society.
Okay. 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 So if there is an increase, like everyone understands, like who's not a
Yeah.
doctor, they feel that maybe it started happening post
Mm.
COVID. Maybe the news are also getting
Mm.
reported
Yeah.
more post
Yeah.
COVID. So other than COVID, what do you think could be the factors affecting sudden
Yeah.
cardiac deaths?
So, the jury is still out on this. The first reaction of the press and the public was they ascribed it to the COVID vaccination and said this vaccination. But, in I think in ICMR, there was a study which they found no association between COVID vaccine and the incidence of sudden cardiac deaths. But they did find a correlation between severity of the COVID infection in those who had it and the incidence of sudden cardiac. Now we know that the COVID infection was an inflammatory process which caused the general inflammation and change of the tissue texture and all that, which gave rise to clotting in the lungs and so on and so forth. And long COVID syndrome, which describes the persistence of the ill effects of that COVID infection, continues to linger even now, I feel. So it has changed something in our body structure, composition, functioning, maybe the clotting mechanism, we do not know, which makes us more prone to small triggers, which may not have mattered pre-COVID. You know, that's
Okay.
what I
Okay.
gather, that it has somehow disturbed the integrity of the human tissue, maybe in the lung, maybe in the brain, all over. And that has made us more susceptible to these ordinary triggers, which may be just a viral infection or a thump on the chest or whatever it might be. And it's
Okay.
predisposing. That's the only way to explain this problem in the young people because it is not the old collection of plaque and things that happen because of age.
Yes.
So that is one. The second factor is a cumulative factor. After COVID, there has been a revenge film, revenge shopping, revenge spending. So we will teach COVID a lesson, so we are going out. So what COVID has done is, in the setting of a heightened health awareness, many young people are seeking out exercises, going to the gym. gym subscriptions has gone up. So again, that is a good attitude to keep fit. But I suspect that there is an overdoing of these things without proper supervision. So if I'm totally unfit and I get this motivation to exercise and I run, 1 kilometer on day one because I'm young, I can do it like 5, 6 days, go to the gym and lift heavy weights. It is unaccustomed exercise which can cause deleterious effects to the body. Okay. Now we do hear of again anecdotal that there are young people who go to the gym and fall. We've had celebrities who've had that problem. Who knows that they may be causing coronary dissections or inducing arrhythmias, which is never gets detected because it's always postscript. What has happened? So my strong suspicion is while exercising is good, the over-exercise mania that has set into the younger population is contributing at least partially to the sudden death syndrome. Because we often hear running a race, they were doing something, they were in the gym, they were jogging when they suddenly fell. There's no other way to explain it other than an arrhythmia or the heart beating fast or slow, or a dissection that nobody talks about. When the pressure inside will cause a tearing of the blood vessel and suddenly block off, you can have an arrhythmias and die.
Okay.
So we will know the exact problem in maybe a couple of years from now, when there will be lots of retrospective cases which have been analyzed post-mortem, and we know what is really the problem.
Why do we always talk in probabilistic manner, like in India? Don't you feel that let's say if we are able to see some correlation, shouldn't there be a formal clinical study?
Yes.
Like for example, post-COVID, why is it happening? Is it an actual correlation, or should we read more into it without that clinical study? Why do we not have that culture?
No, very good question. So this is a epidemiological question. COVID happened in 1920, 2021. Now it's 4 years down the line. And actually data is getting accumulated. So it's not a prospective study of a hypothesis that you can do. This is something that has happened beyond our control. And the ripple effect of that infection continues to occur and present itself in various types of illnesses. And the data is now being collected. So in any medical study which has got significance, there should be at least 5 to 10 years of data, retrospectively.
Okay.
So this is why I said in a couple of years, we will have more clarity on what really went wrong. We are probably midway through that journey. What has happened so far is wild assumptions. COVID vaccine caused this and this caused that.
Yes.
That is the press phenomenon. It's media blitzkrieg that causes this kind of hangama. There's an anti-vaccine lobby that gives voice to this kind of assumptions. But I believe that the infection has probably got to do with the sudden cardiac deaths more than COVID vaccination itself.
Okay. No, I regarding clinical study, I mentioned it because the same should be done as far as gym goers are concerned. Like you said, that going to gym and over-exercising can also cause sudden cardiac arrest. Now, that is also, isn't that a probabilistic theory? As in, shouldn't there be a data-backed clinical study?
So it begins with this anecdotal incidents. Okay, it's not just gym; it's also during marathons and unaccustomed exercise. So there is a common denominator there. Maybe we are doing something above our set physiological limits, and this is why it's important to have a trainer, in a gym. But many commercial gyms don't have trainers and do not have certified trainers who can guide a new customer into saying, well, this is your limit. You cannot lift more than 5 kilos. We are in that, mood to suddenly become very fit. One, that is that. Second thing, again, this it's not an assumption, is my observation that most young people go to the gym not for cardiac fitness. They go to the gym for bodybuilding. There are two types of, when you do bodybuilding, you have to do weights, you have to do isometrics to do that. Whereas cardio fitness training, which is what we are really concerned about, is completely different. It's the difference between a sprinter and a marathon runner. You see that body composition. Sprinters are bulky people because it's the momentum of that bulk. Whereas sprinters, you will never find them. They are skinny, wiry people, who are extremely fit. So this is the difference. There's always a danger in doing isometric, and if it's to be done, please do, but it should be done under a certified trainer who can assess your body fitness, have a doctor's certificate that you've got no other problems like congenital heart problem, which can predispose to exercise-related morbidity, so on and so forth.
Agreed. So do you mean, like, for example, if I have to do bodybuilding, and let's say I want to keep a coach also, hire a coach also, probably the discussion would be what is my goal,
Yeah.
as in, let's say I want to
Yeah.
reduce 10 to 15 kilos, and then the discussion will start
Mm,
from here, and then finally a regime or a
mm,
routine
mm.
will
Yeah.
will be set up. Do you feel that before starting the training there should be a set of tests that one should do,
Absolutely.
and then those tests, the results of those tests should also be considered,
Absolutely.
and the coach then need to
Yes.
prepare a regime accordingly?
So, absolutely, you hit the nail on the head. I would imagine that if I'm going first time to the gym, there's a trainer who
Mhm.
will interview me, look at my medical reports, actually get a doctor's clearance, and then find
Mhm.
out what my goal is. Is it to make me fit, cardiac fitness, or is that, I'm
Mhm.
too lean and skin, my job requires me to have a little personality, and therefore I need to do bodybuilding? There's nothing wrong in that.
Yeah,
Those are the
yeah.
goals which then will be curated for you by the trainer under
Mhm.
controlled conditions that befit the individual. All right. Now suppose he's
Mhm.
got a family history of cardiac death. Okay, he may be fit,
Correct.
but there's diabetes, there's history of young siblings who may have died suddenly. The trainers are trained to recognize that and to be careful. Right? Do you have
Mhm.
lipoprotein A? Do you have a history of long QT syndrome, Brugada syndrome? All these has an
Mhm.
implication. Now, when you do these on your own, there are many people who are doing weights at home on their terrace. They just
Yeah.
buy
Yes.
dumbbells and do this and that, totally unsupervised. This is very
Okay.
risky, So it should be a
Mhm.
very
Mhm.
regulated way by which you seek fitness.
Mhm. Mhm. Have you heard of the name of this company, Fitter?
There are lots of companies. There is Cultivate Fit, maybe. These are all like good companies where I'm sure there are
Yes.
accredited trainers and done under supervision. But I'm actually referring to the by the roadside, 101 gyms that have come up, or
Mhm.
unsupervised gym, because now you can get everything on the net how to make a gym at home. You buy
Mhm.
weights and ropes and all that and do it and then face problems,
Mhm. Mhm. No, the way we are discussing, the name Fitter came to my mind because that seems to be the only company that I
Mm.
have seen which is trying to
Yes,
integrate, in the sense, your weightlifting or your health related
yes,
goals to your
mm.
actual health. They, in their recent transformational
Yes,
challenge, they asked for the medical reports
yes,
also.
correct.
Uh,
Okay, yeah,
yeah,
true.
yeah. Okay, okay. So let's say if I am a layman person, I am 25-year-old, 25 to 30-year-old, and I heard this news that my friend or someone known died due to sudden cardiac
Mm.
arrest, and then first of all, I would like to know, like people generally call it a heart attack. कि heart attack आ
Mm,
गया था
mm,
एकदम
mm.
अचानक. So from I am also a layman. I don't know the
Yeah,
difference between heart attack or a sudden
yeah,
cardiac arrest. I wrote about it on LinkedIn, and then someone pointed
yeah,
it out. But then I was also not able to understand it. I would like you
yeah,
to,
yeah.
throw
No,
light
let
on
me
this.
make it very simple for you. This is a cause of
Yeah.
confusion. Heart attack is a very common word, okay? And
Hmm.
anybody dies of suspected heart problem. There are many heart problems. The understanding is usko heart attack ho gaya. Okay. Now, what is a
Yes.
heart attack? A heart attack is when the blood flow to the heart muscle or part of the heart muscle is blocked because of a sudden
Hmm.
clot that forms inside the artery that goes to the muscles of the heart. Okay, either by
Okay.
a clot formation or, as I said, dissection. You can, because of high shear stress, a part of the wall can just dissect, and that flap will just
Hmm.
like a cork. It can the rest
Hmm.
of the
Hmm.
downflow, blood flow downstream can get affected, and so a heart muscle which is
Okay.
very active then doesn't get its fuel, which is oxygen.
Hmm.
And then it gives you chest pain, and finally within a few hours it will die. That
Hmm.
so
Hmm.
this is heart attack, and sometimes it's caused by the plaque buildup, which is that slow buildup of at the plaque material, the cholesterol, over
Yeah.
several years, and then that might just dissect or rupture and cause the clot to
Hmm.
form. So this is heart attack.
Hmm.
Now remember that
Okay.
this is not something that happens in like that. Sudden
Hmm.
cardiac
Hmm.
death is actually a big bucket diagnosis, which includes heart attack, which also
Hmm.
includes the heart suddenly stopping because the electrical function, which causes it to beat, suddenly stops because of asystole, which means for some electrical failure, there's a power. Okay, so there's no beating. There's no problem with the blood flow, but it doesn't beat. Only
Hmm.
because of
Yes.
very fast beat, instead of 60, 70 per minute, it beats at 200, 250, 300. Completely
Okay.
bizarre what's called ventricular fibrillation, where it is
Hmm.
moving, but it's moving like that. It's not moving like that.
Okay.
So no effective blood flow happens. Within minutes, your blood flow to the brain ceases, you become unconscious. And if you don't do something drastic like an electrical cardioversion
Hmm.
therapy,
Hmm.
that's the end of the story. Okay, so
Okay.
when you say cardiac arrest, the medical person will understand that this is not heart attack; it's a arrhythmia, rhythm disturbance,
Hmm.
either by stopping, intense slowing, or very fast heart rate. Three situations which can cause. And there are
Okay.
medical diseases that predispose to this.
Okay. Okay.
So that's what
Okay.
sudden cardiac arrest is. So, all these dramatic stories that you hear on the press as heart
Hmm.
attack is not true. Anything that
Hmm.
happens and finishes off in 1 hour is sudden cardiac death. Okay. It
Hmm.
can be a massive heart attack, or more commonly, it is an arrhythmic disorder.
Hmm. 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 So let's say if there was this video in which a girl was 23, 24
Yes,
year girl
yes.
was dancing
Dancing on the
in a
stage, yeah,
marriage.
I saw that.
Yes, dancing on the stage, and she suddenly collapsed. Like from one, she went directly to
Yes,
zero. So let's say if something like this
yeah,
happens, and obviously there will be a lot
yeah,
of panic,
yeah.
around. So at that point of time, what should people do?
Right. So, incidentally, I know of this, and from the net information, again, they said it's heart attack and all that. But apparently, she had a sibling who also
Yeah.
had a sudden cardiac death. And according to the press, I've not seen any medical confirmation. She had this condition called hypertrophic cardiomyopathy, which is it's a
Hmm.
medical condition where the muscle is asymmetrically thicker than normal heart muscle, and that
Okay.
predisposes to this kind of arrhythmias. So, induced by this very intense physical effort of dancing. Dancing is intensely physical. May have triggered that, and that's it. She suddenly fell and died. Now, what is it that you can do when you have, you are traveling on the public transport or you're walking and you suddenly find not uncommon nowadays. And normally,
Yeah.
you get so frightened that you tend to move away. But this
Hmm.
sudden cardiac, one of the things that I believe should emerge out of this heightened awareness is there has to be both by the medical community and by social organizations, by clubs, by schools to
Hmm.
learn CPR or what's called first thing
Okay.
is a first responder uh, treatment.
Hmm. Hmm.
So it doesn't matter whether you're a lay person, a young person, or old person. You should be equipped by certain training to be the first responder. Okay?
Okay.
You can be anyone. Okay. First of all, to say that it is our moral duty to help. You may not
Hmm.
be. You can't say I'm not a doctor. I don't know. I may do something deleterious. That's not an
Hmm.
argument. There's a Good Samaritan law, I think, in this country where you are morally bound to attend to somebody who's fallen
Yeah.
down. And what do you do? There
Yes.
are first responder courses. I'll tell you very simple. You may have seen, somebody having a fit on the road. I have seen people put the juta, on the face because that's the traditional.
That's what we have seen in
Yeah,
movies.
exactly. Movies also promote this. Completely wrong.
Yeah.
I've seen people pouring water over an unconscious patient. Dangerous. These are
Yeah.
actually the things you should not be doing. Okay, but you
Okay.
can't blame the people because they are going only by the info that they have seen on movies and traditionally followed in. So
Hmm.
there is a need to have schools, colleges, organizations, employees, everyone be familiar with first responder.
Hmm.
What do you do when somebody
Okay.
falls down? Make sure that he is not crouching, his neck is extended, and he's breathing. If he's breathing,
Hmm.
then
Hmm.
some kind of a breathing assistance will be given, which will lead you up to step number two, which is basic life support. Okay, which
Hmm.
is a
Hmm.
little more complex, but I think bus drivers, bus conductors, pilots, crew, all these people have got trained in BMS. They are trained.
Hmm. Hmm.
No rocket science. It's basically about telling how do you give chest compressions because the survival improves till medical help arrives. Okay,
Correct.
until the ambulance comes on the spot. So the critical, if there is no first response to a cardiac arrest, the survival is under 10%. But if you
Hmm.
go through
Hmm.
that sequence of first responder treatment, basic life support, advanced cardiac life support, medical help, then the survival improves to 80%.
80%. Okay. Very
So
nice.
this is now a public need. It's not restricted to the
Yes.
medical domain. Right from senior school onwards, this is a life skill. It may happen to your own
Hmm.
dad or
Hmm.
grandfather at home, and you should know. Okay. So first responder treatment is what is done. Then basic life support, which includes basic chest compressions. The prerequisites for chest compression, like you should be on the flat on a hard surface, not on a cushion or anything like that. You must
Okay.
make sure that the patient is breathing. If he's not breathing, can you do mouth-to-mouth resuscitation? Yes, if the person is known to
Okay.
you, you can. If the person is not
Okay.
known to you, it's your choice whether you want to or not. But there are ways by which you need to bring physical contact by some
Hmm.
oxygen that can go in. and then you call for help. As you do this, ask somebody to ring 108 or the helpline number so that the ambulance arrives. And once the ambulance arrives, you can back off and let the ambulance paramedics do the rest of the job.
Yes, yes. Like I've seen in the US and UK, probably what you said, this is taught in schools
Yes,
also. Like there are so many reels on Instagram that I've seen where small children were able to save the life
absolutely.
of their known or a friend. And like so much is happening. Probably, again, I'm trying to connect it with data because now we are, playing that probabilistic game. We don't have the data, so we are never able to talk about the gravity
Yeah,
of an issue. And probably we're not able to include it in the
yes.
implementation or a policy level change. Don't you think that, as you said, children in school or maybe in colleges should be taught
Yeah,
about it
absolutely.
in their constructive
No,
ways?
I would agree. See, I feel that, I mean, we don't have the power to do this, but I'm talking about the powers that be. They should really
Mhm.
have a think tank that goes into the public health hazards that we face today. Not just this, it's about increasing pollution, increasing traffic deaths,
Yes.
and all the public social determinants of ill health has to be
Mm, mm,
addressed in a very simple public health manner. So it's a matter of policy that instead of making fifth grade students be introduced to AI, okay, it is
mhm,
better that they
mhm,
learn life skills. And today's children are just don't have life skills. How to
mm,
cross the
mm,
road, how to start a bank account, how to transact, how to talk.
mm.
Life skills are very important for their own benefit. So this is a
Yes.
socio-behavioral engineering, which is today the
Mm,
need of the hour as a prerequisite for health.
mm, mm.
Because recently you may have seen there is a study that's been published that atherosclerosis is now affecting children under 10. They are
Mm,
diabetics, they
mm.
are pre-diabetics, there is evidence of cholesterol. Imagine 10 years from
Yes.
now, when they before they reach 20, they will be having stents inside and bypass and things like that. So to me, this is a public health emergency
Mm,
induced by manageable, controllable lifestyle.
mm, mm.
Eateries and all the junk food that they are consuming, sedentary habits, so on and so forth. So I feel that it must become a policy, a mandate for schools to have sessions on first responder, life skills, CPR, basic life
Yep.
support. It should be mandatory for colleges. Without that,
Yes.
they don't get their certificate or don't write an exam or whatever. It should become part of all employee organizations that
Mm,
everybody in the
mm.
organization has to pass a BLS test. You may
Mm,
never need
mm.
it in your life, we pray, but in case you need, it may be your closest friend who is having a cardiac arrest. And you might
Yes.
just be the savior because before the ambulance comes, you are the point person who will determine whether that patient survives or dies. Now, in
Mm,
Chennai,
mm.
there was a cardiac surgeon who, in the hospital, was doing rounds, collapsed,
Mhm.
and emergency, I believe, was 200 feet away, but they couldn't save him. This is what
Okay.
happens even in a hospital setting. So imagine what happens on the road.
Yeah. In the hospital, people must have known
Yeah.
about
No,
all
I'll tell
these
you, in the
things.
hospital, there's a problem. There's always an assumption that, doctors are there, nurses are there, they will do it.
Doctors are
But I tell you, it's the sweeper, the housekeeper who can make a difference. I have seen, on the seventh floor of a private ward when there's a collapse, it is the first response by the housekeepers who often,
Mhm.
provide the link between life and death by just removing everything so that they prepare everything, make sure that suppose somebody has an accident. I've seen people lifting them. You should not. He may have a spinal injury which can cause paralysis. This is
Yep.
knowledge, and this should be disseminated widely today. This is the need of our
Mhm.
country, mission
Mhm.
and
Mhm.
so on and so forth. Yes.
You've raised a lot of valid points. Um, like from a personal point of view, this question comes to my mind a lot. Like for example, in lifestyle, one thing is that you're not taking care of, you're not doing any
Yeah.
exercises, and you're not maybe
Yeah.
eating properly. But again, more than that, the question that comes to my mind is, does sleep affect your cardiac health?
Yes.
For example, I'm trying to sleep at least 6 to 8 hours, but it is difficult in the sense that there is so much data overload in mind. Like even if I remove screens at around 9, still I still have to I sleep around one
Yeah.
or two. So what is there a correlation between sleeping less and getting
Absolutely.
deteriorating your
Very,
cardiac
very good question. Very relevant. So let me just step back to give you a
health?
little broad perspective. We never realize or understand why a day has 24 hours, not 30,
Yeah. Mm.
not 18. It's a number
Yeah.
divisible by 3. And traditionally, we have all had shifts which are always 8 hours.
Yeah.
And
Yes.
the child has to sleep An infant sleeps 18 hours, but children generally says you must have 8 to 9 hours of sleep. Why? That's because the nitty gritty or the nuts and bolts of life, okay, are based on an equal distribution of work, rest, and diet. Okay. So if you divide, I believe if you should divide 24 by 3, it's 8 hours of work, okay, 8 hours of sleep,
Yes.
and 8 hours of what I call life. Now, this is what is not defined. What is life? For some people, work is life. For many people today, the modern corporate lifestyle or academic lifestyle or hospital lifestyle has totally ignored that there is a life beyond work. You are working so that you have a life. You're not living
Yeah.
because you need to work. Work is a means, it's not an end. So, in the
Agreed.
recent decade or so, this equation has been completely disrupted by, ambitions of success, more money, more fame, more publications, more this, more that, and all that. And you can't generate more than 24 hours a day. So, what has happened? Your work has intruded into both your life on one
Yeah.
side and sleep on the other side. This is the reason why we are all sleeping less. I myself am from 18-hour shift background as a medical person. Somehow we are alive today. I don't know how, but we are alive. But I'm telling you that today's thing is not just about work. If you look at our children, unknown to you, your children have sleep deficits because you sleep in your bedroom. They are not sleeping. They are happily browsing their smartphones late into the night. Okay,
Yes.
either watching movies or Instagram or whatever, and they sleep at 2 o'clock, 3 o'clock, and next day they have to go to school with 4 hours of sleep. How much mental energy will they have? So they sleep in class. They are not attentive. Their scholastic performance dips. Their mood changes. This is
Yes.
something which is an epidemic today. Parents are not aware or say, "Chalta hai, it's okay, they will learn, they're getting a lot of information." So that
Yes.
sleep deficit, remember that your brain grows during sleep. Brain doesn't grow when you are engaging the brain in very intense activity. You're burning the energy. And during
Yes.
sleep, that's why a child sleeps 18 hours, because that kid's brain is growing. It sets everything into proper perspective, and then you are fresh for the day. There's also
Agreed.
physical, return of energy back to you, and you need that critical 7 to 8 hours of sleep. And when you get old, the old people have to also sleep more because their reserves have depleted. So,
Agreed.
unfortunately, our modern lifestyle, which includes healthcare as well, is ignoring this divine natural principle that you just need 8 hours of sleep. It's most important. Your life for which you're doing all this is what your purpose, your determination, your enjoyment, your family, your personal hobby, your divinity, your spirituality, all that is part of why you are living, for which you need livelihood, for which you earn. Now, I'm not
Yes.
saying that you should not work only by the clock 8 hours. No, you can work 9 hours, but you make sure that at the end of the day, it's all balanced out.
Yes.
That is what,
Yes.
in fact, sleep deficit, to coming to your question, is associated with cardiac problems, is being associated with mental problems. And there is enough evidence to predict that they will have early dementia if you have chronic sleep deficit. Apart from mood changes, apart from depression, apart from relational conflicts, apart from decision making deficits, because it is sleep that sets you back as a human being early in the morning.
Agreed. Agreed. So you're saying that there is a lack of boundary in today's work
Absolutely.
culture. Ideally, you are like eating, breathing, work only. And let's say if the company says that we work for 12
Mm,
hours a day, we eat, breathe, and sleep,
mm.
work. And if you have to join a company, then you have to,
Yeah.
agree to that
Yeah.
idea. And once you agree, obviously you'll always be in sleep
Yeah.
deficit. And because you're not aware of what happens due to sleep
Correct.
deficit, you will, unknowingly, you will take this burden on
Correct. Correct.
yourself,
So initially, it's
which your salary can't compensate because that's not
So
on the work.
initially, it is a mandate. You have to work because you need X amount of money for your family, for your personal needs. And then that gets encoded into you. So even if there is no mandate, you continue that pattern of overworking and, personal ambitions. I have to do overtime. I have to do double shifts, things
Yeah.
like that. That is one. That's work related. Today, it's entertainment related. That by choice, you decide to watch a movie late into the night, 2 o'clock, 3 o'clock, especially
Yeah.
children. It's a big problem because we are going to see a society in 10 years' time that's got completely disrupted in values and, the psychiatric problems that young people have. Mind boggling. Our own Indian data shows that.
Mm, mm, mm. So, do you think that, like, I'm just continuously thinking of who should take the onus or who should take the responsibility? Let's say if doctors are doing their job, hospitals are accustomed to their own way
Yeah,
of thinking, and these new problems
yeah,
are coming up. And let's say the government is also taking its time and slowly moving into building
yeah,
a policy.
yeah.
Till then, who should take the
No, I think, see,
responsibility? Do you feel that
primarily it is a
corporate? Yeah.
responsibility of people in the field of health, in the field of public
Mm,
health, in the field of humanities, in the field of
mm,
behavioral sciences, psychiatry, mental disorders, to be very proactive in informing the public. Some of it is happening because of internet. We must compliment the play the role, but you can't trust the internet information because it exaggerates, it underestimates. There are political
mm,
overtones. So, but it at least gives a clue that something is going wrong. Okay. Now,
mm,
this
mm.
has to be picked up by the lawmakers of the country, the Ministry of
Yes.
Health or ICMR, proactively, not because the government is not expected to know the nuts and bolts of these problems. Okay, they will
Mm,
react to only what is brought to their table. One, and second, it has a major political benefit for them. Otherwise, it gets ignored. Now,
yes.
unfortunately, there's so much of data that we have, but there is no bureaucratic response or government response to say that, hey, we have a major, major problem. We are talking about being the third largest economy only on financial
Mm,
metrics. We are goofing up.
yep.
We need to be a nation of educated, well balanced, matured individuals for which you have to
Mm,
invest in today's school children. So, what about
yes.
their diet? You look at the rubbish that the canteens in the schools have, beverages
Mm,
and patties, and they talk about good health in the class, but the canteens provide rubbish. Who
mm,
regulates
mm,
it? So it is
mm,
primarily the government, but they must have the inputs from this whole domain of health sciences, behavioral sciences, public health,
mm.
academics. Unfortunately, we don't have a channel to them because they
Yes.
find convenient forums to take inputs from. Policy based
Mm,
on what the industry tells them, packaged
yep.
foods and so on and so forth. You know, so
Yes.
roadside
Yes.
companies are
So
contributing heavily. I would say
yeah.
that the food aggregators are passively contributing to the metabolic
Mm,
problem of young people by providing this to the doorstep. First of all,
mm.
food is bad.
Agreed.
Even that little effort to go and get that food is taken off
Mm.
because it comes to your table.
Correct.
And what
Convenience.
are they doing? They are happily lounging on the sofa with watching the movie and eating away. You know,
So, from an awareness level, you're saying that there are two kinds of awareness. One is the knowledge-based awareness. The other is
yes,
narrative-based
yes,
awareness. So, in India, we have seen that because I don't know, psychologically, maybe we are still slavish. Maybe we have been enslaved by thousands of years. So maybe we are run by fear psychologically. And until unless someone says that by doing X you might die, no one takes a step. So maybe we are still in that narrative
yeah,
awareness phase, wherein the question sort of what I'm asking is, if people are dying early, so what should be done? So I am also doing the same narrative, probably
mm,
awareness, because that is
yeah,
what works. Like that is what movies also promote. Like if someone was dying and or maybe someone is
yeah,
unconscious, you throw
yeah,
water on them, they will obviously regain
yeah,
consciousness. How should we transition into a knowledge based
yeah, yeah,
mindset,
yeah.
I would say?
No, see, again, I'll have to step back to see. See, I'm not.
Mm,
See, there are a lot of things that have transformed healthcare in this country. We're very proud of the fact that today we can match the best healthcare systems in the world as far as therapy is
yes.
concerned. Okay, which is good because now we can safely ask somebody in the US or UK or Europe to come and they get the state of the art, maybe a shade better than what they would get in terms of speed and all
Yes.
that.
Yes.
So that's a huge achievement. Okay, but what is not happening is that corporate social responsibility, not to
Exactly.
give money and say somebody run private. No, that we must step out of our ivory towers as we do this. We must
Mm,
understand and acknowledge that there are major social determinants of, we used to say social determinants of health. I always say social determinants of ill health.
mm,
That is
mm,
what will make or break this nation. Many small
okay.
countries have got onto it. Cuba, Venezuela, even Bangladesh is a
Mhm.
shade better than us. So
Okay.
we have to create this ecosystem where it is not one domain initiative, but it has to be something that starts from education, Ministry of Education, school education, college education. It has to be a mosaic that has stakeholders from different domains, primarily
Yes.
focused on not on our illness, but how do we make sure focus on the next generation of our today's 3-year-olds, 4-year-olds, 5-year-olds are the potential leaders of tomorrow. Are they well? Are they balanced? Do they have values? Are they learning the right things? Do they have the right approach to life? Is not being addressed because we are so engrossed in exceptionalism of being the best, medical tourism. We are the best and we have the best doctors. All that's true. But it is going to be a bubble that we will find difficult to hold on to if we don't address primary and secondary healthcare issues in this nation. Now, you go to Delhi or any city for that matter, there is no definite policy on pollution.
Yeah,
You stay in Delhi, so you know. You can't see at a distance of 20 feet. Okay, so you can
especially after Diwali.
you blame the farmers that they're burning stubble, but that's a smoke screen. Literally, the pun is not intended. It's a smoke screen. It is the vehicles who are, the unregulated manufacturing of vehicles, the not being unroadworthy, the vehicles not being discharged at the end of 15 years or 10 years. This is not, we don't have a solution. We may have an even number, odd number. Those are all band-aids, But if Singapore can regulate vehicles on the road, why can't we? The children who are breathing the Delhi air today, take it from me, in 20 years, they will have permanent lung fibrosis.
Okay.
It will give a lot of material for lung surgeons to do transplants and all that. A lot of money will come. But I think we are doing a great disservice if we don't address these preventable causes. Cleaning up our rivers and things like that, The speed control on traffic. Why do we have so many accidents? We have excellent roads, but why do we have, it's just a matter of policy not to allow animals on the road, but nobody does that. It's just a policy that anyone coming opposite on the wrong side will have their license cancelled. Remember that, when a young man of 40 dies in a road traffic accident, it's a whole family that is subject to poverty and healthcare issues. Health insurance is getting, inflated. So there are a lot of public health. See, I'm a specialist. I've lived my life in tertiary care. But I have learned, I wish I had known this earlier, that now in my role, I see the public health issues and I feel very sad that a nation of such eminence is not addressing these problems, which all of us should be addressing in every process.
Yes. Now that we've talked about the problem and you have also raised a lot of points on the solution side, I would like to discuss first of all, on an individual level, what are the tests one can do as far as taking care of cardiac health is concerned from a preventive point of view? And second, once we establish these tests, how can we scale it up for the larger population, for people in tier 2 or people in lower economic section? How can we reach out to those people? Like you have also touched upon insurance, probably the insurance. We'll also talk about insurance.
So it's a very thoughtful question. So with what we are seeing today, with people in the young age having metabolic problems, it's not sudden cardiac death, but there is a moving of the erstwhile older diseases into the young age bracket. We would never hear of anybody under 30 being diabetic. Today, we are hearing people in under 20s being diabetic, under 10 now pre-diabetic. Dr. Mohan's recent publication, which has gone into Nature Medicine, is an article worth being looked at by the policymakers of this country, for exactly what we have discussed. So, in terms of what is the screening we should do, I feel that those who have got those children, kids who are born with congenital heart diseases like a hole in the heart, etc., will get detected by the Well Baby Clinic and pediatricians anyway. But I think the first general checkup today must happen between the age of 10 and 15, where your cardiac risk factors, metabolic risk factors are screened. What is it? Apart from, not an ECG and all maybe not be required, but lipoprotein A, homocysteine, thyroid, all these things that are the hidden risk factors, which have got a genetic basis as well, which predisposes them to later cardiac disease, must be screened. And ECG to see whether they got long QT syndrome, whether they got an arrhythmogenic right ventricular dysplasia and certain cardiac conditions can be identified. Now, once you identify, the parents are aware that yes, my child is more prone to heart disease, so some extra care needs to be taken. Okay. Having done that, assuming that all is normal, the next checkup should be between 21 and 25, where you can step it up to see whether you've got, your HbA1c and all the other things that blood pressure, all the other risk factors that come in can be screened, maybe cholesterol to know whether their cholesterol is okay or not. If all is well, the next one should be between 31 and 35. It's an easy calendar, 20 to 25, 30 to 35, 40 to 45. After that, of course, it's left to the discretion of the attending doctor to do the screening because many diseases like prostate and cancers and all those things should be covered. Now, we are only talking about cardiovascular. I would add the cancer screening markers, with either in 20 to 25 or 30 to 35, because we are seeing cancer breast, cancer pancreas, colorectal cancers in young people. You are in a hospital system. Never heard of before 40 years ago. So something related to the diet is happening. And accordingly, the primary physicians must get them onto a healthy lifestyle program. Your mental makeup must be assessed, either 10 to 15, or what are your type A personality, are you, exposed to depression. So, and then you create a matrix of these factors. There's a way by which you can score it and tell them you are high risk, moderate risk, low risk. And accordingly, tailor the diet, exercise, medication, and checkup schedule for the next decade.
Okay. So basically, what you have done two things. One is you have divided this screening into age brackets. That is one. And second, what you've done is you have talked about two kinds of tests. One are regular tests, HbA1c, blood pressure. The others are probably the bigger tests. I would like to dig deeper into this. What should be the frequency of bigger tests or heavier tests, or maybe expensive ones, and the other the frequency of the.
So let's take the bigger tests post 20. I'm saying post 20 because we are now seeing heart disease between 20 and 30. Okay, so to catch it early. So I wouldn't be averse to including some cancer markers, like BRCA for women, and CA125 or whatever it is, in that screening panel. Okay, at the age of 20. Now, if all is well, they just need to go on with a reasonably normal lifestyle till the age of 30. Okay? At 30, definitely every lady must have a pap smear, must have a mammogram. All men should have prostate screened and maybe a colonoscopy. They recommend once in 5 years. I would say once in 10 years if is okay at the age of 30. Now, the moment you cross 30, the frequency of these tests must increase. It must become once in 5 years. Because you can have a cancer developing, going to its extreme stage in that interim. So to minimize or to mitigate the risks of undetected disease, a colonoscopy, gastroscopy must be done at the age of between the age of 31 and 35. Now, doing all this, does it mean that everyone will be 100% healthy? No, there will be surprises. But you will significantly reduce the ill effects of these diseases, for the next decade. So this is the scheme I would propose today in the setting of new findings of diseases, which is moving down the age bracket.
And do you feel you're paying so much for your insurance premiums, at least in tier 1 cities or people who are working in corporates? Do you feel that it can be mandated from the insurers also?
Yes, I think so. See, the insurance industry also must now get into social responsibilities. It is, you and I know that it is sheer business. Camouflage with good words and brochures and all that. But it's a very ruthless business. I know because I worked on the other side of the insurance. It is discretive. They use their discretion who to pay, who not to pay, and it's for people who get affected badly. So therefore, while that may be a business paradigm, it's okay. But they also need to get into a CSR mentality. And they are also stakeholders in the health status of the nation. Now, I don't believe that you need, if you take 1.4 billion people, let's say 1 billion people, of which 70% are in the rural, semi-urban geographies, I don't think that premiums need to be that high to cover their basic disorders on a preventive mode. In the insurance industry, in their own interest, would be prudent for them to get into the health awareness campaigns that we talk about. It is in their interest not to have people coming to the hospital, but they don't take part in health awareness creation today. There has
Yes,
to be
yes.
a mandated. See, the government of India says 2% of your financial outlay for all corporates must be given for CSR. Does it include?
Hmm.
It
Yes.
does. I'm happy to know that, but I'm saying the insurance industry must put aside 2% of their, their huge income for
Hmm.
health awareness, preventive things, all on the prevention side. It helps the community. At the same time, it helps the business interest to minimize the number of people seeking healthcare for which they have to pay.
There is this constant uh, direct. You're talking in two terms. In the sense, one, you're saying that either healthcare is
Yes.
business, or there has to be a CSR
Yes.
activity. Can't there be something in between, which is maybe socially
Yeah.
responsible and a little
No,
bit
no, no.
profitable also?
That's exactly what I'm saying. So, if you look at the CMC Vellore model, we are
Hmm. Hmm.
defined non-profit.
Yes.
Better than me that no hospital ecosystem can run without profits. Not just to sustain its patient care, but to maintain standards, to plan for capex for future development, so on,
Hmm.
unforeseen expenses. So there's no problem with that. But if we take a moral decision that we also have a corporate social responsibility, something like a Robin Hood philosophy, muted.
Hmm.
And while we do this, we will also take care of that segment that cannot afford our care.
Hmm.
Okay. So I'm saying that the health insurance industry can do whatever it's doing. If they
Hmm.
also commit that 2% or 3% or 1% of our total income, we will devote to creating health awareness.
Hmm. Hmm.
It comes from their coffers.
Okay.
Whichever method, it can be community work, it can be movies, or it can be webinars, or whatever it is, so that it serves two purposes. One is keep people healthy,
Hmm.
also minimize to a certain extent the number of people who will seek health care for which the insurance will have to pay.
Yes. Yes. And let's say, um, so from the
Yeah.
implementation side, I'm assuming, let's say, it is difficult to change hospital and insurance
Yes, it's very
industry.
different.
So should there be a third party outside of these two
Yes.
ecosystems? Maybe you are convincing them to pay you the
Yes.
money
Yes.
or invest some money
Yes.
into you, and then you start working on society level longevity or
Yeah.
illness.
No, I'll tell you where, Piyush, it's very important.
Because I'm trying to find out a way to
Yeah.
scale it up.
No, it's a good idea. If there is you can imagine the corpus of such a third party ecosystem will have to be very high. Okay. Where that will
Yes.
come from, I do not know. But there is another problem with the concept itself. See, unless the
Mm-hmm.
providers also
Mm.
show an equal commitment to this, it will
Yes.
only be another resource of money which can be potentially mismanaged. You understand? With no
Correct.
no
Correct. Yes.
disrespect to anyone.
So basically, extra
Yeah.
OPDs for
But
IPDs.
if I have a stake in it, I'm also committed to what you're doing. Then it becomes there is a synergy of purpose. You know?
Mm.
And
Mm.
so it's not easy, but we'll have to think about it and discuss as to how we
So basically, you're saying that there has to be an overarching
accountability commitment.
accountability to this, commitment and
Yeah.
accountability to this. That can come from the government also, from a
No,
policy
the
level.
reason why I'm saying this is we hear this population dividend is India's strength and we are a young nation and all that. Very true. We are unique in this. But imagine if a young
Mm.
population of tomorrow is beleaguered with ill health.
Mm.
There is a population dividend advantage.
And secondly, let's say if we are in tier one, um, we have around 65-70% doctors are in tier one. Still, we have some bit of awareness in tier one. And the moment we go to tier two, let's say if I go from Delhi to Sonipat,
Yeah.
my hometown, the level of awareness is, I would say, 10-20%, not more than that. And obviously, there are fewer doctors over there. And the knowledge level of doctors also
Yeah.
changes depending upon what kind of
Yeah.
people or what kind of
Yeah.
patients you are seeing. So, in tier two, which is the real Bharat, is there a possibility to, let's say you talked about this screening methodology, is there a possibility to reach out to that audience and
Yes.
come up with a structure or
Yeah. No,
something?
I'll tell you. Again, this is something that is happening, which I believe should not happen. The
Mm-hmm.
strength of any. You look at all the successful healthcare systems of the world. There is a bottom of the pyramid, layer, or the middle of the pyramid layer, which is the strength of the healthcare ecosystem. Now,
Yes.
in India, we've all grown up in that. Today, there is nothing called the family doctor or the
Yes.
family physicians in a group practice. See, for tier
Yes.
two and tier three cities, it is extremely important to not
Mm.
hijack that system, but to allow it to
Mm.
grow. No,
Yes.
because my family doctor is my friend. All right. I have the freedom to
Yes.
approach him middle of the night. He will come with his worn out leather bag and an old stethoscope. But he has a time to talk to you and advise you
Hmm.
what to do, what not to do.
Hmm.
He's your first point of trust contact. And he will
Correct.
also triage you to the right tertiary care system.
Hmm.
But
Hmm.
if what is happening today is in cities like Pune, 100 hospitals have been sold. Small
Yes.
hospitals have been devoured by big brands. Very sad. Okay, it may be good business, but you're actually preventing these people who had these things catering to their private needs, not only in terms of basic healthcare, but also in terms of awareness. You know,
Hmm. Hmm.
because they have time to talk to you. They come home. You can visit their clinic. They are social
Yes.
individuals. They are not tied down with extremely busy schedules. They are friendly. They are open. They are transparent. So somehow we must allow that to grow. It is only in our interest,
Hmm.
that we get the
Yes.
people who really need tertiary care for which there is insurance, but all the other common ailments can be tackled by them. I mean, see, 60% of even tertiary care hospital OPDs are common ailments. Today, if you have some
Yes.
cough, it doesn't need major investigations and loss of money. You can tackle it at the primary level. So we must ensure that it is an NHS-like system where my first point of
Hmm.
contact is a primary physician who will then put me on to
Hmm.
the district or however.
Hmm.
It's very healthy to do. So that is
Agreed.
a layer where your question will be answered, that we can use this in tier 2 and tier 3 cities to make it really
Hmm.
robust.
Agreed. Agreed. And actually, there are from I have understood that there are two reasons. There could be two reasons which I come to think of. First is maybe hospitals are selling themselves because there is no money to expand
Hmm.
otherwise available. Like there is no investor who is coming to you and giving you the money
Hmm.
to expand. You have to rely
Hmm.
on banks, and banks in itself by nature are not that risk taking
Hmm.
entity. Second is probably not many doctors are business trained or maybe that
Hmm.
aspirational. Maybe lack the knowledge of
Hmm.
open a hospital. It could be because the certifications are so many and it is very difficult to
Yeah.
get into this market. Is what I have learned probably. So initially, maybe I was also opposed to private equities and other bigger investors acquiring
Hmm.
hospitals. But later on, I could understand that probably there is no money otherwise. There is no money to expand
Hmm.
your hospital. Like for 25, 30 years, a doctor worked
Hmm.
diligently, grew that hospital one or
Hmm.
two units. But then now he wants to expand. There is no
Hmm.
other way. There is no other way to go about it.
Yeah. Yeah.
Probably.
Agree that it's in today's different ways by which healthcare functions. It's become difficult for smaller players to survive because there has
Hmm.
been increased awareness of seeking tertiary care hospitals. Headache, I want a neurologist. I don't want my GP. What does he know about neuro? So that is over a
Yes.
period of time. That whole thing. Even villagers would like to come to town, and because somebody has told them that's where you will get good care. It may be a tumor and all that. So
Hmm.
that is true, and that is making the family practice system impoverished. There comes a time when the doctors also have to look at their own, future of their business and their
Hmm.
families and all that. ठीक है, छोड़ दो, अब बेच दो इसको, you know. So that's understandable.
There is another problem. There is a second
Is
generation
there?
problem
There is
also.
nobody to take over and all that. So I fully acknowledge that there is a business paradigm issue that has come up which never existed. But I'm only saying,
Yep. And plus, I talked to a lot of doctors, and they say that they spent 10 years into getting a degree. And other than that, it is
yeah,
not difficult. 10 years is study, and then clearing the exams is
yeah,
another 5, 6 years because you fail, you pass, you
yeah,
fail, you pass. And overall, by 35, best case scenario, you have completed your
yeah,
post graduation
yeah,
and super
yeah,
specialization. Now, let's say you are aiming to do something, but
yeah,
there is no money. You go to a hospital, the salaries that you earn are
yeah.
peanuts compared to what a
True.
usual, computer
Yeah,
scientist or studied from a
yeah,
normal
yeah.
college would earn. Why is it that? Like it is probably like what will you do?
True. No, these are tractions that are very contemporary. See, there's also another factor, Piyush. My father hardly spent anything to educate me. But today, if you have to educate your child through medicine, wherever it is 10x. You know,
Yeah,
so
definitely.
he may have to take money, borrow money. There may be bank loans and all that. So there is a pressure today on the fresh graduate that never was there 10 years ago for you to be socially
Mhm.
minded. You have to pay back. You have to also look after your parents, maybe siblings, and all that. So a lot of these factors are responsible for the changed outlook of medical practice. There were never
Mhm.
a tertiary care system that is so powerful today at that time.
Mhm.
You know. So there was a larger inflow of patients. So we are in the midst of a transitioning, a transitioning system. But I'm only saying a conceptual. See, I would say that tertiary care hospitals must handhold, even if they are selling off, buy it, but let them not go out of the system, but handhold them
Hmm.
into their practice, because it is based on years and years of trust,
Agreed.
which the people I know, there are patients who complain, डॉक्टर साहब अब हम क्या करें, हमारे डॉक्टर साहब तो चले गए, बेच दिए, अब हम क्या करेंगे, it is so important to have trust as your edifice of care, and
Hmm.
so it's
Hmm.
about hand holding. It is not about replacing or substituting. It's about hand holding.
Hmm.
But have no doubt that the private family physician, family practice system remains the
Hmm.
linchpin of healthcare transformation in India even today.
Okay. Okay. So to summarize your point, uh, it can be scaled if the family physician, the family doctor, which is by nature everyone understands in India, is taken care of. If that model is
Mm,
somehow scaled, and second is that to scale you need money, and that money will come from sources who are mostly business minded. So there has to be a win-win
absolutely.
scenario uh, to it, and plus whatever ecosystem we have to work according to
Absolutely.
that. So we have to think of it in the
Long.
long run. The business person in my in me is I'm just
Yeah,
thinking
yeah,
out
no,
loud.
please.
Let's say. Uh, so you can't be a 1 to 2 year
Yeah.
person or 3 to 4 year. It could be a decadal change that you'll
Yeah.
have to plan. Otherwise, it will
Very
be very
different.
difficult to sustain. Okay. Now I have very
Sure.
specific questions from a few
No
family
problem.
members. Uh, One question is that let's say you stay in tier two city and you get your MRI done, and then you go to a tier one city and you have to do the MRI again because the doctor says that it's not clear, so you'll have to do it again. But in tier two also you spent the same money. Maybe you'll spend 20-25% extra in tier one. So his question was, why is it so? Why are the charges not according to the kind of machine over there, and how can a patient be conscious
No,
about it?
good question. Again, this partially answers the issue that we were discussing. So imagine if that tier
Yes.
two system was part of the larger umbrella, this problem will not be there.
Mhm.
Okay. So there are two factors, and I'll be very open about it. Imaging is
Mhm.
one of the biggest revenue generators. There are three the revenue generators in our big system: pharmacy, laboratory, imaging. You can add a
Okay.
fourth, which is OT. Okay.
Mhm.
So every large business-oriented healthcare system invests heavily into imaging modalities, laboratory spectrum,
Okay.
and the what was the third one? I said pharmacy. Huge
Pharmacy.
margins. Okay, so these are lifelines for as far as the business is concerned. Now, when you have a tier two, let's say unconnected tier two hospital, coming to a
Hmm.
tier one hospital where there is pressure on the individual to generate revenue. Okay, and there are pressures. Let's not deny. He will
Yes.
always find something that is not up to the mark. MRI, either the
Hmm.
contrast was not given or it was done on a one test and apparently
Hmm.
it was only 64 slides. I need 16 slides, I need 64 slides. Now, these are
Okay.
individual decisions which we cannot question because these are, specialist. We can't question that. We
We
can't
can't
question
question.
that.
Yes.
But I'm saying that there is an element of let me do it again because I would like to see my own hospital results. So repeat
Hmm.
many of these tests unnecessarily. All it takes
Hmm.
is for your conscience to come in and say, can I manage? There's already a diagnosis. It's good enough. Let me not pay 10,000
Hmm.
rupees to the patient on an extra thing which has already been done. Because
Hmm. Hmm.
these are all very high precision instruments. It's very unlikely
Yes.
today that an MRI from a tier 3 or an MRI versus an MRI from a tier 1 will be significantly different. No, it's not like X-ray to a scan. These are extremely high precision. So we must let the filter of our heart come in and say, ये जरूरत है क्या? Can I save this patient some money? That will
Hmm.
make a difference. All right. So
There are two questions
yes.
leading to this. So sorry, you
No, no, no.
conclude first
This
and then.
this is the sum and substance of it. Even I've had this bias that I can't trust the laboratory test that was done somewhere, so let me do it again. But it has left patients
Hmm.
unhappy, and I had to explain why I repeat. It's not that I want to. CMC never expects you to generate revenue for them, but it's because of the laboratory standards, the laboratory error, the NABL accreditation, and all that. When there's an element of doubt, when it's crystal clear, there's no need. So it is there. So that's why I said we cannot question any clinician's decision to ask for a repeat scan. It may be valid, but where it is not needed, we must err on the side of the patient because he's paying the money. My approach,
Yes.
okay, because see, money will come from another source, but that patient's resources are limited. And it's bounden my moral duty as a doctor to also care for that patient as a whole person, which means his pocket. I must be conscious. Okay, so this is what I would think the difference between tier 2 and tier 1.
And let's say, is there a possibility of, just this question came to my mind, is there a possibility of integrating AI into older machines and making their results proper? Let's say if there is some
Yeah.
difference, can that be?
Yes, I think so.
using
I think
AI?
so. AI is a very powerful tool which can make precision and accuracy, come up to standards. I'm not sure about the investment that they will have to make as a patch that comes on, and whether that will get passed on to the patient. In which case, the cost of doing that will then start to match with that. So these are fine nuances, which we need to consider when you look at.
And basically, you're saying that the eventual decision maker in this case is the doctor in tier 2 or
Absolutely.
tier 1. Even though there is
Yeah.
AI or better technology with
Yeah.
precision, still there
Yeah,
could be other
absolutely.
issues. There was a similar question on
Yes.
stenting also. The question was, like, what should be the ideal blockage you should get your stent? That is one. So his point was, for example, let's say you go to a hospital, you're pushed into angiography, and once you are into angiography, you obviously get angioplasty done. And okay, fine. But let's say if you're putting a stent in your body, how should you know whether that stent was proper or what they said? Because it is going into your body. First of all, when should you get a stent? What should be the ideal blockage from a patient point of view? Let's say if they have to ask 1 or 2 questions.
So, there is the textbook recommendation is any narrowing of a blood vessel or heart artery, which is more than 50%. That particular lesion is a candidate for intervention. Okay. And in most cases now, it is usually a stent. All right. Now, it is possible that you may have a 90% block and you are completely asymptomatic, and it was detected on a routine executive check calcium CT scan, or or a routine angio done for some other purposes, where you will find it's the clinician's call, because a 90% block is a looming time bomb. You might have a blockage. It doesn't take much to block it. So even though you are not having so many symptoms, it's a correct thing to stent that because it is nearing 100%. Okay. Now, so again, the textbook recommendation is if there are 2 to 3 blocks which are in the proximal vessels, which are amenable to easy access, you can stent it today. Okay. But if there are more than 3 blocks, it's the cardiologist's call to say whether whether it is better to do a bypass. Again, that decision is dependent on his overall fitness, his age, his comorbidities, his surgical complication rate, etc., etc. I have done 5 stents for somebody who was totally unfit for surgery, but I have sent people with just 3, who were suitable for in terms of age and fitness, and the correct age in which bypass would tide them over into their old age. And so these are again very clinical decisions, which I think most people follow the norms. There is an element of doing overstenting, again because of the same reason that I mentioned. In several hospitals, your salary is linked to the revenue you generate. But I believe that it's a minority. Most people would do the right thing. So stenting is convenient because you can do it and next day you can walk out. And blood anti-clotting drugs that we have today are excellent. Unlike the old days, you get back to your normal and you save your heart vessels for a bypass. When you are at the right time. So, 50-year-old, 60-year-old stenting, it will give you 10 years. You can then decide whether you can have a restenting without who wants to get the chest cut open, if possible.
Okay. And what kind of stents are these? Just 1 or 2 questions, let's say, because from patient side, there is no family doctor. So there is mistrust. So they would want to ask, or they
So I'll tell you, very good question. So this is where your family doctor comes in. See, he has no stake. He's a neutral umpire in this. So he trusts you, you trust him. He knows your family background. He knows your family income. So he will say, Baba, this is what you should do. So you already got trustworthy advice from an intellectual, from a professional, with which you go to a healthcare tertiary care where they may say this way or the other, but you've got a benchmark to fall back on so that you make your personal decision. All right. Now that includes whether a stent is needed, whether it is the right time to do it, what type of stent is needed. Today, drug-coated stents are the gold standard. In the old days when I started, it was all bare metal stents, stainless steel. Today, there are better alloys which create less clotting and less complications. It is coated with drugs like sirolimus and everolimus and things like that, which makes it, the restenosis, that is, the reblockage rates have fallen down completely. There are also biodegradable stents, which means you put it today,
Yes.
and over a period of time, it just gets absorbed and nothing happens.
Okay.
These are all not one size fits all, but these are decisions that are based on clinical parameters and the discretion of the attending cardiologist.
Okay. Actually, one question on these two questions, one question came to my mind, which I tried to discuss with my wife because she's also a doctor. And probably you have also covered that point. My point was maybe angiography is an invasive procedure. And once you are on the table, the doctor has to take a decision because he's already in. Now, is there a way to judge the blockage without non-invasively? You just rightly pointed out CT
Yeah.
calcium.
Yeah.
I would like you to throw some light on other
Right,
non-invasive
right.
procedures.
A good question. So, if you are a 40-year-old executive, who is leading a very busy life, you have some risk factors, and you just want to know, are my heart arteries okay? There is no need to subject yourself to an invasive procedure. You can go to a doctor, and the doctor might ask for a calcium CT, CT scan, and a thing which can be. This is a test that can be done walk in, walk out. We'll just give you a contrast, just an injection, and then the CT will spin and it will generate a 3D image that has got. It is not 100% accurate, but in my experience, in my practice, I find that when that report is clean coronaries, normal, that's enough. It's reliable.
Okay.
But when it says there is a 70% block at this point, there is another 40% block at this point, there is an error. It may be true, but there is an overestimation, underestimation problem. And if the patient has got risk factors, again, the doctor decides, Baba, you are traveling, you are going abroad, you're traveling, you're alone. You better have, now that it's an index of suspicion that has been raised. And that test helps you to go to the next step, which now is necessary. And now you already in your mind, okay, I'm anticipating a 70%, 40%. You'll be lucky if the actual angiogram says, no, it was not 70, it was only 30. You are at peace. In case it is 70 or more, well, you're already halfway there. The doctor will tell you on the table, why we have found a lesion. Okay, shall I do it? It's your choice. Most people will say, Aap kar do, doctor sahab. Anyway, you're halfway, you're already in my coronaries. He will just another 10, 15, 20 minutes, and that's everything is done.
Yep.
So this is the approach that should have. Now, should everybody should have a CT angio? No. It all depends on your risk factors, your symptoms, and all that. Should everybody who has a CT angio go for a regular angio? No. Those who raise suspicion, they should go. Okay. So there is a step ladder process that you can use. Okay. Use it systematically, it becomes scientific, it becomes justified. Do I subject everybody to a regular angiogram? Not at all, because you could die because of an angiogram if you're unlucky. It's an invasive procedure. You're putting in contrast, which is toxic to the kidney. So you want to avoid it as far as possible.
Agreed. So now in this last section, I want to understand what is your role at ITC Healthcare. You're working in such a big organization. Probably just wanted to understand what is your role and what is the spread of that.
Okay, so I was inducted into ITC in 2019. Basically for a directorial role because they had cast their vision into CSR supported healthcare initiative. And me, because I was in a not-for-profit in somewhat the same space, there was a synergy that they could see in my type of approach to healthcare and what they had a vision for. So I stepped into that. There were others also came. We were a team that looked into corporate social responsibility backed healthcare. We took a little time to find out where the needs are. And we have now got 3 projects that are running in villages. Okay. fully supported by the organization, which is in Saharanpur, in a place called Munger in Bihar. Now, recently in Kamrup, we have no hospitals over there under us. It is completely village. Okay, it is remote, and we have developed a self-designed system of mobile medical units, which are four-stem vehicles, specially fabricated to have a doctor, an A&M, a pharmacist, and a lab person, apart from driver and cleaner, to go into the village every day, 5 6 days a week, and set up roadside clinics and attend to the most basic health need at all ages, from pediatric to antenatal care to geriatrics. Most of them can be tackled there itself. There is a bench that can be converted to a couch in the van itself.
Okay.
There's a doctor. We've outsourced this to another company to provide the manpower for us. And on an average, 60 to 80 patients are seen every day, every vehicle. And in Saharanpur, there are 7 vehicles that go in 7 different directions every day. There are a few who can't be managed. They are sick. Remember that these are people who will never access healthcare because they are too remote. There is no vehicle and there is no money. So the best is done for them on site, and those few, maybe 1 or 2 a day, we bring back to the base, and we have a memorandum of understanding with the private health clinics, where we admit them and they get treated for secondary level care, tertiary level care, for which we pay. And
So
this
very
is
nice.
what we've been doing. We've seen about 3 lakh patients in the last, since 2022 when we started. And the impact factor is huge. We are now set on our next target of creating a 100-bed hospital to make it completely project in-house, which means we'll have to employ manpower and all. But that's the next phase. Right now, we are looking at spreading this horizontally to have more places in villages where there's a huge need for it.
So basically, so that doctor who goes in that mobile van, so that doctor is a family doctor for them.
Not really. Well, in a sense, yes. So it's only one doctor. It's a junior doctor. It is not one person because the attrition is very high. These are people who are preparing for NEET exams, and therefore they come there.
Okay.
But the outsource agency constantly provides someone. Okay. We have a huge. I can share with you the FICCI award for this eye care, which we have had with Prof's Eye Care in Noida, I think, who provide eye care on the spot. Which is done from these vans, and that has just 2-3 weeks back, has got the latest FICCI award for.
Very nice.
So this is a lot of eye care, but there's a scope of expanding into antenatal care. Right now, it's only like a GP, like as you said, a family doctor, but it's not one person. It may change over a period.
Agreed.
So that's how it functions.
So there is a chance of expanding
Yes.
horizontally and
So we'll
vertically.
want to scale it up at some point. It's in that phase where this is again my perspective that this is a company that was never into health, but had the courage and vision to get into a completely alien domain. They needed to understand the nuanced nature of healthcare, where the needs are, how to make it effective and impactful, and to be committed to that corporate social responsibility. So right now it is fulfilling, and now that we will probably have a brainstorming to see how we can, increase it vertically to increase the scope and scale per section, and also to see whether other geographies can. It's all in North India because that's where it is the greatest.
Very nice. Very nice. Lastly, like you have had huge experience into private bodies and CSR activities and public sector. What are the challenges or learnings that you would like to pass on to people like me and younger audiences so that they don't make the same kind of mistakes?
In terms of what? In terms of healthcare as a whole, or
it could be as a person. I would like
okay, so it's I myself have, as I mentioned, I was a completely hard-nosed clinical person. My life was just seeing patients, huge numbers, 60 to 80 patients every OP day. And the next 2 days you're in the lab, and then it just goes several years. There was it was like a frog in the well, which most doctors are. There's no world beyond that, and we feel very comfortable that this is all there is. That's not the truth. There's a wider world, and ITC gave me that opportunity to be the frog off the well, outside the well. To see that there are lots of factors that impact healthcare. Okay, like social determinants, poverty, the scenes that I saw in Saharanpur were heart wrenching. When you go to these bastis and see the kind of life they lead, the kind of food they eat, the total abject poverty written on their faces. Uh, you feel ashamed that you can still claim that you are the best healthcare system in the world, really, for the majority of our countrymen. So what is it that we can do? We can't cover everything, but there's a perspective that comes into it which is more broad based. And I think every doctor, every professional, every investor, every private equity must make a visit to these villages to see what is the scope of this yeoman work that you are getting into. Right now, our healthcare system is extremely focused on metros, and the people who are rich and famous have insurance. We are doing very well on that, but it is at the cost of huge deficits, which, in my opinion, and data will back this, is only growing. If you look at the trajectory of cancer care in India post-COVID, history of sudden deaths, history of heart disease, history of mental disease, history of accidents, history of diabetes, we are the capital of the world. This is despite a huge presence of private, top of the state-of-the-art healthcare, which we are now opening it to foreigners. So there's a huge gap that is developing on the underbelly of this good health system. As you raised this question, who addresses it? Me. So everybody must have this broad-based, big canvas picture, and administrators, financiers, investors, doctors, laboratory brands. Everybody must take this upon themselves that we really want a nation that is thriving, and by keeping with the Prime Minister's vision. It is important to also veer away from just GDP and third largest economy and infrastructure and roads to see that people's health is in jeopardy, serious jeopardy. So that is learning.
So stay connected to ground realities. Okay. Thank you, Dr. Chandy, for being so open and transparent. It is very difficult to have a deeper discussion nowadays, and I found it very easy to talk to, even though I'm quite.
No, that's okay.
Maybe you had to entertain some of my,
No. There's never any question that is not smart. All questions need to be asked, and it's because we don't ask simple questions that we are going off on a trajectory. So ITCs and now this Good Health Clinic, which is a outsourced firm, where we are trying to see how we can extend this to the employees as well. Okay, because there is a huge healthcare problem in big organizations. In terms of all that we said, heart disease, cancers, all organizations. Why it is there even in medical organizations?
So you're saying that this model that you're developing can be applied to various corporates?
Absolutely. Not in the exact same format, curated to breaking down, fragmenting healthcare issues in terms of lifestyle. The 888 formula of importance to diet. We haven't talked about that, but diet is now becoming a factor that is responsible for your mind, for your heart, so on and so forth. So, a lot of new insights are coming, but these insights are misused by the commercial, and this, that, and all that. But there is a science in it which we need to address. It's basically to return back to the basics, which we have ignored in our pursuit of, happiness and so on and so forth. So that's my message.
Okay. So in the next podcast, maybe 6 months down the line, we'll dig deeper into the science and try and quantify the problem statement more. Probably, actually, I need more preparation.
No problem. Anytime you let me know, and I will. You will send me a copy of this, whenever it's ready.
Yes, definitely. First, I'll send
I
you
need to share it with the ITC people also, because it's again information and orientation for them. Okay. Towards.
Yes. First, I'll edit it and then I'll share it with you.
Thank you, Piyush. Good talking to you, and